So good morning, everyone. My name is Maura Gibney. I'm the Director of Organizational Development for California Advocates for Nursing Home Reform. My co-presenter today is Bea Layugan. She's our Advocacy and Lawyer Referral Specialist. And we are going to be talking about Medi-Cal eligibility and home and community-based services. So first, for those of you who may not know what CANHR does, or maybe are only familiar with one specific part of our services, we are a statewide 501c3 nonprofit organization. We get calls from across California on a number of issues on our toll-free consumer hotline regarding long-term care planning and options, Medi-Cal eligibility, and Medi-Cal recovery. We get a lot of calls about nursing home and assisted living facility admissions, transfer discharge issues. We also can answer questions about hospital discharge issues, and a lot of calls about residents' rights. We also operate a statewide lawyer referral service, and we do community education across the state, including the one that's being hosted today. We have people truly represented from across the state today, so we're so thankful for all of you that are joining us. CANHR also engages in a lot of policy and administrative advocacy to change the way the systems work that provide long-term care and make them better and more accessible. And we also engage in litigation when there are harmful things that happen to people who, older adults and people with disabilities. Okay. So today's agenda, we're going to be talking about Medi-Cal eligibility for specific programs that serve individuals who are age 65 and older and individuals with disabilities. We're really focusing today on the home and community-based services that are available through the Medi-Cal program that are covered by Medi-Cal. And we're going to be talking about Medi-Cal recovery. So I do want to mention for some of you that were interested in long-term care, skilled nursing facility coverage, that's not the focus of today's presentation, but we definitely can answer questions related to those issues. Please feel free to give us a call, and we'll also be hosting other consumer events throughout the year online surrounding those topics. So I'm going to now turn it over to Bea, and she's going to start us off with Medi-Cal eligibility.
Hi, everyone. Okay, so my name is Bea again, and we'll start off with the overview of Medi-Cal. And Medi-Cal is the health insurance for individuals with limited income and assets. It's called Medi-Cal in California, but it's also known as Medicaid in other states. Medi-Cal pays for long-term care in hospitals, nursing homes, and at home. Examples of home care would be in-home supportive services, also known as IHSS, and home and community-based alternatives waiver, also known as HCBA. Besides home care, Medi-Cal also covers different services within the community, such as adult day healthcare and case management. Next slide, please. Thank you. And there are different types, or there are different Medi-Cal programs available for people in different situations. You don't necessarily need to remember the eligibility criteria for each one that we'll talk about, because when you apply, Medi-Cal will use your income, assets, and even age to determine which program you will go into. If you experience a change in income or assets, you should definitely let Medi-Cal know to see if you qualify for a different program, which may have better coverage or less out-of-pocket costs. Next slide, please. Thank you. Alrighty, so here's the comparison of the different Medi-Cal programs. The first program is called MAGI, Medi-Cal, and MAGI stands for Modified Adjusted Gross Income. To be eligible, you must be between the ages of 19 and 64 years old, and you cannot have Medicare. There is no asset limit for this program, so that means that you can have $500,000 in the bank, and that won't necessarily make you ineligible for MAGI. The reason for this is because eligibility is based solely on your income. So the income limit for this program for a single person is less than 1,564. So you have to make less than 1,564 a month. And then for a couple is 2,106. Those are the limits for 2022, effective as of April of this year. And then it goes up every year. If your income is below these limits, that means you fall within the 138% federal poverty level, which means you would be eligible for MAGI. Unlike other programs, you cannot use deductions such as healthcare premiums to reduce your gross income so that you can meet that limit. And then lastly, for Magi, there is no look back period for transfers. And a look back period is when Medi-Cal looks at any transfers or gifts that the Medi-Cal recipient may have done and determine whether the transfers make them ineligible for a certain amount of time. So luckily, there's no look back period for this specific program. The second program is called Aged and Disabled or Medically Needy Medi-Cal. To be eligible, you must be 65 years or older or blind or disabled. Right now, the asset limit for this program is $2,000 for a single person and $3,000 for a couple. These limits, however, are changing in July, but I'll go over those changes in a few slides. If you're married or have a registered domestic partner, participating in a home and community-based program may qualify you for spousal impoverishment, which allows the spouse that is not on Medi-Cal to keep additional resources. Assets are the determining factor of your eligibility in this program. So if you don't meet the asset limit, you will not qualify. Your income, however, will be treated in a different way. Your income will be used to determine whether you have a share of cost or not. So if your monthly income is $1,564 or less for a single person and then $2,106 for a couple, you will be eligible for Aged and Disabled Medi-Cal, sometimes referred to as no share of cost Medi-Cal, because you'll receive coverage for services without any out-of-pocket costs. However, if your income is above those limits, you will have a share of cost and you will fall under medically needy. This means that you'll receive coverage for services after you fulfill your out-of-pocket obligations to Medi-Cal. If you receive home and community-based services, again, spousal impoverishment protections also apply to income. So this will allow the spouse that's not on Medi-Cal to keep additional income for themselves. There is also no look-back period for this program. And income is, sorry, I just saw the question on the chat. Income is counted monthly. So the third and last program is called Long-Term Care Medi-Cal. There is no age restriction as long as the applicant is in a skilled nursing facility. You must be institutionalized to be part of this program. The asset limit is $2,000 for the person in the nursing home. And then if spousal impoverishment protections automatically apply if the person is married or have a registered domestic partner. And then the spouse at home can keep additional assets for themselves. The asset limit for this program is also changing in July, so just keep that in mind. And as far as income, the nursing home resident can only keep $35 for themselves. What will happen is Medi-Cal will take your gross monthly income when you're in a nursing home, subtract $35, and then the remainder of that will have to be your share of costs to the facility. There is a look back period for long-term care Medi-Cal. It goes as far as 30 months. So what happens is as soon as the person enters a nursing home and you transition to long-term care Medi-Cal, Medi-Cal will look at any transfers that you've done or gifts that you've done within the past 30 months. And depending on the amount, that may make you ineligible for a certain number of months. Next slide, please. So next we'll talk about share of cost. You will have a share of cost. Like I said, if your accountable income is above $1,564 if you're a single person, and then if you're married or you have a registered domestic partner, you'll have a share of cost if your monthly income is above $2,106. The share of cost is the amount of money that you must pay out of pocket each month towards your medical services, supplies, or equipment before Medi-Cal begins to pay. Think of it kind of like a monthly deductible. When you are approved for Medi-Cal, and if you happen to have a share of cost, Medi-Cal will do the calculation for you and then let you know what the share of cost is in your notice of action. If you're a little bit over the income, so let's say you make $1,600 a month, and you're trying to get down to $1,564, you can actually purchase supplemental medical insurance, such as vision or dental insurance, to bring down your countable income. So then once you are down to 1,564, you'll be eligible for no share of cost Medi-Cal. Next slide, please. Thank you. And so here's an example of how share of cost is calculated in the community. So Seth is 65 years old. He's single. He lives at home and he receives $1,650 a month in his pension and Social Security benefits. He has less than $2,000 in the bank. So that means that he'll be eligible for Medi-Cal based on his assets, but because his income is higher than 1,564, he will have a share of cost. To calculate this, we'll take his gross monthly income of 1,650 and subtract an income deduction for unearned income, which is $20. And this is just an automatic deduction that Medi-Cal does for unearned income during the application process. And then from there, we'll subtract $600 from his net income. The remainder will be his monthly share of cost. And as you can see, his share of cost is $1,030, which basically leaves him with little to live. And that's because the $600 is the maintenance need level that the state thinks a single person can live on per month, which hasn't changed in years, which is why it's so low. But luckily, there's legislation right now that aims to increase that number. So the number may change in the future. With Seth, because he makes $1,650 a month, he can potentially purchase additional healthcare insurance to bring down his countable income. So you'll see here that he can purchase $66 worth of dental or vision or any supplemental insurance to bring down his countable income to $1,584. And then when you deduct the $20 income deduction, it brings him down to 1,564, which will then make him eligible for no share of cost Medi-Cal. Next slide, please. Thank you. Okay, and then just briefly, for someone in long-term care Medi-Cal, also if you're in a SNF or nursing home, the way that your share of cost is calculated is by taking the gross monthly income, so in Seth's case, $1,650, and then just subtracting the $35 personal needs allowance. His share of cost of the nursing home will end up being $1,615. If Seth receives VA aid and attendance benefits, he can keep an additional $90 on top of that $35. But then if he is eligible for SSI, or also known as supplemental security income, he can keep $50 instead of $35. Next slide, please. Thank you. Thank you. So one of the many misconceptions about Medi-Cal is the assets that they look into to determine someone's eligibility. Medi-Cal does not count all of your assets. They actually break it down between exempt and non-exempt assets. Exempt assets are not counted towards your eligibility, but non-exempt assets are. And so next slide, please. And then, so here's a list of exempt assets. So this is a list of assets that you can have, and it will not count towards your eligibility. You'll notice that the primary residence, also known as one home, is exempt. So that means that the Medi-Cal recipient will be able to keep their home and then have that not affect their eligibility towards Medi-Cal. Other exempt assets are household goods, personal effects, jewelry, one car, IRAs or work pensions, as long as the Medi-Cal applicant is taking out regular payments of interest and principal, or depending on your age, the RMD also counts. Whole life insurance policies with a face value of $1,500 or less are exempt. Term life policies are completely exempt. Burial plots and prepaid irrevocable burial plans are exempt as well. $1,500 worth of designated burial funds are exempt. And then lastly, the $2,000 asset limit cash reserve is exempt, as well as the community spouse resource allowance of $137,400. In addition, we do have a fact sheet on real property and how that is treated. It may or may not affect your eligibility. So if that happens to fit your situation, I definitely recommend reading that fact sheet. Next slide, please. So now we'll talk about a really huge change that's happening. It's a huge win for Medi-Cal recipients and applicants, which takes effect July 1, so in a few weeks. The new asset limit for a single person is 130,000, and then for a couple is 195,000. So instead of 2,000, it's 130,000, and then 3,000 instead of 3,000, it's 195,000. Huge change. The second phase plans to eliminate the Medi-Cal asset test completely, and this will take effect no sooner than January 2024. So the state plans to eliminate the asset test completely in the future, but the first phase of that plan is the asset limit increase happening in July. So two things to note about this change is that income guidelines will stay the same. So share of cost rules and calculations will remain the same. So unfortunately, even though there is an increase in asset limit and you can get, and Medi-Cal is more accessible, if you happen to have a really high income each month, you may have a really high share of cost each month. The second thing to note is that this asset limit only applies to Medi-Cal. So if you are on SSI or supplemental security income, you still have to follow the SSI asset limit rules. Next slide, please. So now it will transition over to spousal impoverishment protections. This is for people who are married or have a registered domestic partner. When one person in the couple needs Medi-Cal with home and community-based services or is placed in a skilled nursing facility, the spouse at home can get extra income and asset protections under spousal impoverishment. Under these protections, the spouse who is not on Medi-Cal, also known as community spouse, and that's the term that I'll be using from now on. The community spouse, also known as the spouse that's not on Medi-Cal, is allowed to keep extra income and assets in their name, while the Medi-Cal spouse receives skilled nursing services either at home or in a nursing home. Next slide, please. So the income protections allow the community spouse to either keep all of their income and potentially receive additional income from the Medi-Cal spouse. If the community spouse makes less than the minimum monthly maintenance needs allowance, which is $3,435 for 2022, the Medi-Cal spouse will be able to transfer some of their own income to the community spouse so that they can meet that limit. So let's say the community spouse makes $2,000 a month. It's less than $3,435. So that means that the Medi-Cal spouse will be able to allocate up to $1,435 of their own income to the community spouse. And then on the other hand, if the community spouse makes more than the minimum monthly maintenance needs allowance, spousal impoverishment allows them to keep all of their income without having to contribute to the Medi-Cal spouse's share of costs, if they even have one. So if the community spouse makes $6,000 a month, let's say, they won't be eligible for an allocation, but they can keep all of their income. The asset protections allow the community spouse to keep up to $137,400 in their name, and that's also the amount for 2022. This amount is called the Community Spouse Resource Allowance, also known as the CSRA. The community spouse can have up to this amount in non-exempt assets, while the Medi-Cal spouse can have up to $2,000 in their own name, which again will increase on July 1 to $130,000. So that means that in July, the Medi-Cal spouse can have $130,000 in their name. And then if they qualify for spousal impoverishment, the community spouse will be able to keep the CSRA. So they'll be able to keep a lot more money. And next slide, please. So then what actually happens during the Medi-Cal process when spousal impoverishment applies? Someone applies for Medi-Cal. Medi-Cal looks at the couple's assets together at the date of application. It doesn't matter who owns what. They just look at everything the couple owns as a snapshot. Once the Medi-Cal application is submitted, the couple has 90 days from the date of application to make sure that the Medi-Cal beneficiary only has $2,000 in their name, while the community spouse keeps the remaining assets of up to $137,400. Again, the asset limit for the Medi-Cal beneficiary is changing, so keep that in mind if you're going to be applying in July. The CSRA and the minimum monthly maintenance needs allowance are expandable through a court order or fair hearing. You'd have to talk to an attorney to do this, and our lawyer referral service can definitely help you find an attorney if you need help looking for one. And then lastly, in addition to the $137,400, the community spouse will be able to keep any IRAs or pensions in their own name. Doesn't matter if they're taking out payments or not. As long as it's in their name, it'll be exempt. And then they're also going to be able to keep any other exempt assets. So let's say the home happens to be in the community spouse's name only, not in the Medi-Cal spouse's name. That's completely exempt. And they'll also be able to keep, they'll also be able to keep any after acquired assets. So for example, if the community spouse receives an inheritance, they can keep that without jeopardizing the Medi-Cal spouse's benefits. And so next, I'll turn it over to Maura Gibney, who will go over the different home and community-based programs available for Medi-Cal recipients.
And apologies to Bea because my computer mouse decided that it wanted to go back in time. So good morning, everyone. So I will be looking now at the specific home and community-based services that are available once someone is eligible for Medi-Cal. So what are home and community-based services? These are programs that offer an alternative to nursing home placement for people who wish to remain in the community. So someone that can stay at home, but they just need additional support. Services include things like personal care services. So depending on the program, and we're going to go into each one in detail, there's things like help with chores, meal preparation, grocery shopping, supervision hours, in-home nursing care, center-based programs, home modifications, case management services. So different programs, some are available across the state, and then some are not available in all counties. They're very limited to specific counties or certain zip codes. And one of the key things to know that we get asked time and time again is, how do I apply for the umbrella term home and community-based services? As you'll see, there are a lot of different home and community-based services, and unfortunately, you need to apply for each program individually. So we're going to go through the slides and tell you how to access each program. But it's important to remember that you need to apply for each individually, that you have to have Medi-Cal in place first, and each program has its own guidelines. One thing too, as Bea mentioned, for spousal impoverishment, if a married couple or registered domestic partner is in need of those additional kind of asset protections or income allocation, as long as one spouse is on Medi-Cal and becomes eligible for HCBS program, that can help gain them spousal impoverishment protection. So we get a lot of people who have only heard of spousal impoverishment in regards to nursing home placement, but it's important to remember that for the programs that I'm going to be going through, people can also receive spousal impoverishment protections if they're eligible for an HCBS program. And that includes being on a wait list. So the first, and I don't want to say most common, but maybe most accessed home and community-based service and kind of most widely known is a program that's under IHSS or in-home support services. It's called the CFCO program, or Community First Choice Option. And I think one thing you'll notice throughout our presentation is that Bea and I have included a lot of the acronyms or letters for programs. And quite honestly, this is because that is the most frequent way that these programs and terms are used. So when you are engaging with these different systems, a lot of the professionals that you will talk to when you're asking for services are familiar with the terms by their letters. So it's very common for people to say IHSS, and that's why we include them here. So IHSS is a program that pays for in-home community-based attendance services and support. So this would be a program that pays for an in-home caregiver for household chores, personal care services, paramedical services, and up to protective supervision. So there's no age restrictions for this program. Previous to CANHR, I worked in the developmental disability system, and there, IHSS can be received by a child. It's a needs-based program. So people are eligible for IHSS and CFCO based on their individual needs. You must, for CFCO, meet a skilled nursing level of care. And because it operates statewide, it's very accessible throughout the entire state. There's no waiting list, but the reason for that is that you choose your own worker. So when I say that there's no waiting list, the issue for many people across the state right now is that there's a shortage of care workers. So if you have a family member or friend or a spouse who can do the work, then there's no waiting list. You apply for IHSS. Usually it takes about 45 days. I've heard of it taking a little bit longer for the entire assessment period. But if you have someone in your life, a circle of support, who are already providing that care, then they can be paid for that care as long as they're legally allowed to work in the United States. The problem is for those people who don't have family and friends who can be the IHSS worker, while there are registries where you can get an IHSS worker, there's just shortages. And I think we're seeing that across all industries right now. If you're in need of spousal impoverishment protections and you are already receiving IHSS, you can call your Medi-Cal worker and ask if you have a 2K aid code. So this would help you put spousal impoverishment protections in place. And so one of the questions that was submitted in advance is whether, if you have share of cost Medi-Cal, can you pay your IHSS worker as part of meeting your monthly share of cost? And the answer is yes. So the way share of cost Medi-Cal works with IHSS is Medi-Cal tells you this is the amount of your monthly share of cost. That's the amount you must meet in medical expenses every month. One of the ways you can meet those medical expenses is by paying your IHSS caregiver. And even if it's a family member or friend, then Medi-Cal would pay any amount over that share of cost, which could be the remaining approved hours. It could be your prescription medications, whatever other services you may need for that month. So in order to apply for IHSS, you must be eligible for Medi-Cal. So we get calls on a regular basis of people saying, I want to sign up for IHSS. Please tell me how. I requested the application and they told me I was denied. I couldn't fill out the application. Have you applied for Medi-Cal? No, I have not. So the first step is applying for Medi-Cal. You must be eligible for Medi-Cal before you even request an IHSS application. Then you would contact your local county IHSS office to begin the application process. We've included several resources here, including a CANHR fact sheet on IHSS, but I want to point out the Disability Rights California Self-Assessment Guide. So part of the IHSS eligibility process is typically pre-COVID, it was an in-home assessment. Some counties are doing over the phone and virtual still, but there is some type of an assessment interview to understand the Medi-Cal beneficiaries' needs. What are their specific needs? What does a typical day look like for them? If you are getting ready for that assessment interview, it would be really helpful to read this Disability Rights Self-Assessment Guide. And there's also a self-assessment worksheet that you can fill out or have your caregiver fill out so that the IHSS worker really understands what your total amount of needs are and then can make a better decision about how many hours to give you. There's also a fact sheet here on understanding share of cost in IHSS so that people can understand and do the calculation for themselves and see whether their share of cost makes sense to combine with IHSS hours. One thing to remember, there is no Medi-Cal recovery when you participate in CFCO or IHSS. We'll be talking a little bit later about Medi-Cal recovery, But this is the idea that Medi-Cal, after your death, can go after your estate and get money back. But if you participate in IHSS, that would not be something that would cause Medi-Cal recovery. So we'll go into more detail about Medi-Cal recovery in just a little bit. The next home and community-based services program that we're going to discuss is MSSP, or the Multi-Purpose Senior Services Program. So this is a case management program. It's geared towards helping people age 65 and older to remain at home or in the community. Services can include medic alert systems, adaptive equipment, could be like a shower chair or installing grab bars. They could provide nutrition services or respite care. One thing they can also do is help people who may be unfamiliar with the services and support in their community better connect to those services and support. So if you had an older individual who maybe wasn't aware of IHSS or the local senior centers or what kinds of transportation were available in their community, MSSP could provide case management services to help that person enroll in different supportive services to help them stay at home. The people who participate in MSSP must be 65 or older, and they must have a skilled nursing need. If they were to not receive these services, they would likely need to go into a nursing home. It's also important to note that for MSSP, you must not have a share of cost. And there is a enrollment cap across all programs statewide. So you would want to contact the local MSSP program in your area to find out what their waitlist situation is and see how long, because some MSSP programs may not have any waitlist, and another one in, let's say, a more populous county like Los Angeles could have a waitlist. Just to note one more time, if you are in need of spousal impoverishment and you have officially enrolled yourself in a wait list for a program, that still allows you to gain those spousal impoverishment protections. So how to apply for MSSP? You must be eligible for Medi-Cal. It is limited to only 46 counties in California, and you need to contact your local program to apply. So if you think that MSSP might be something you're interested in, or you are a service provider, social worker, someone that's helping people connect to services, it would be good to find out if MSSP is even available in the area that you work. There's also a resource guide that I've included here. And it's important to note that MSSP is subject to Medi-Cal recovery. So participation in MSSP could cause Medi-Cal recovery, but we're going to talk about the steps you can take to protect your estate from recovery. So don't just say, well, then I'm not participating in MSSP. There are services you can receive from Medi-Cal that could cause Medi-Cal recovery, but there's also steps you can take to avoid recovery. Again, wait lists vary by program. The next program is the Home and Community-Based Alternatives, HCBA program. Just because we wanted to make it extra confusing, we've included an acronym that sounds a lot like the first acronym we used. So there's so many different programs, and so I'm not going to pretend that it's easy, and that's why CANHR is here, and many other nonprofits across the state provide counseling for these different types of services. So we don't expect you to become an expert in the different home and community-based services today, but we are giving you this information so you kind of get an idea of what the landscape looks like. So HCBA provides case management, in-home respite services, in-home nursing and supportive services, CNA hours. It can also provide facility to community transition support services. So you can apply for HCBA while you are in a nursing home or a hospital, and they may be able to help with the transition to the home. But what they provide is a lot of in-home care. Again, it is similar to that IHSS program I described. It's really based on the individual's needs, their specific need for in-home care, their specific health conditions, whether they have a G-tube, whether they have injected medication. So there's a long list of things that would help that HCBA determine how many hours and what types of services an individual would receive. But the goal of the program is to help someone avoid nursing home placement, or to help someone who's in a nursing home or a hospital come back to the community. So services can be provided in the home. They can also be provided in a congregate living health facility or an ICF facility for individuals with developmental disabilities. To be eligible for HCBA, you must be at risk for nursing facility placement within the next 30 days or have already been living in a facility or a hospital. So that would be a nursing home or a hospital for more than 60 days. This is available statewide and the wait list varies month to month. They have a dashboard on the DHCS website that shows you the current wait list. But from my understanding, was helping someone contact their local HCBA program. The wait list is not as long as some of the other programs. So it is something that really does vary month to month. So it would be, if this sounds like it's a good program for you or for one of your loved ones or your clients, it would be good to contact the local program in your area. So in order to apply for HCBA, again, you must be eligible for Medi-Cal. And you need to apply through the waiver agency that serves your specific county or zip code. So for example, in Los Angeles County, I think there's something like 4 different agencies and you need to go through each agency's zip code roster to see which one is the program that serves that specific community. So I've included the link there so that people can look and find their specific waiver agency. There's a really good Disability Rights California fact sheet about the HCBA waiver as well that goes into detail about all the services it provides. And participation is subject to Medi-Cal recovery, but again, you can take steps to protect your estate from recovery, and Bea is going to be talking about that in just a moment. Next up is CBAS, or Community-Based Adult Services. This is a day health program, so a center-based program that provides health, rehabilitation, personal care services, social services. I believe they also provide meals during the day. This is for both older adults or adults with disabilities, where they can go during the day, have a place to go that's safe, that they can acquire some social activities, also get some rehabilitation, but a service that helps them remain independent in the community. So this can include therapy. I'm sorry, I should look at my own slide. It does include nutrition and hot meals, and they will also help individuals arrange transportation. You must need a skilled nursing level of care or have other cognitive disabilities. It's important to note for CBAS, they do include dementia as one of their qualifying conditions, while some other programs don't. This program specifically will serve individuals with a certain level of dementia diagnosis. CBAS is usually administered by the managed care program, and the eligibility is typically determined by your managed care plan. But it's also available through fee-for-service Medi-Cal or private pay. So for example, I was helping a woman who was caring for her father at home. He made $4,000 a month. And so if we look at the calculation that Bea shared earlier, his share of cost was enormous. And really at the end of the day, when I talked to her, what is your goal? What do you need to keep your father at home? She just needed a break. So she said, I'd really like a place for him to go 3 days a week, where I can just, clean the house and not have to worry about him, but also get him out of the house. He gets a little bit of social interaction. So her local CBAS program, their private pay rate was something like $120 a day. So you look at what he would have paid in a share of costs, which is somewhere in the neighborhood of, $3,300, $3,400. And then you look at private paying CBAS. And so for her, that worked for their family. So it is just something to know that while Medi-Cal, may not always be an option, there are some programs where people can also private pay. CBAS is available in all counties across California. There are 270 centers statewide. So in the case of that family, they lived in San Francisco. Within reasonable driving distance from their house, there were 3 different CBAS programs. So it would be important for her to, since she was going to private pay, to contact each one, kind of see which one better meets her father's needs, or whether they, have a wait list. There's no enrollment limit statewide, but center to center, they may have their own wait list if they're already at capacity with the people that they have in their program. To locate a CBAS program in your area, I've included the link here for CBAS programs across the state. But if you are in Medi-Cal, you would want to contact your managed care plan for a referral to a CBAS center. If you have a high share of cost, it may be more affordable to pay privately. That's something that we just discussed. It is one of the few programs that considers the dementia diagnosis as a factor in the needs assessment. And CBAS participation is not subject to Medi-Cal recovery. Next up is Program for All-Inclusive Care for the Elderly. So you will hear this referred to as PACE because otherwise it's a mouthful. So PACE provides a combination of both in-home care services, and this can include cooking or cleaning, in addition to transportation to center-based adult day programs where participants can receive medical care, meals, rehabilitation, therapy, and social services. PACE programs are run throughout throughout the different counties in different ways by different organizations. And so we've even heard of some that will do a participant's laundry during the day, and then they go home with their clean laundry. We've heard of a PACE program that offers acupuncture. So they're really kind of wraparound programs that provide both the in-home care that someone may need, as well as a center-based program. They also contract their own providers. So if someone did not have a family and friend that could maybe provide IHSS services, PACE might be a nice option. This program serves people who are 55 and older, who meet the requirement for skilled nursing, but are able to reside safely in the community. It is only available as a managed care plan. So what that means is you must be willing to give up your managed care plan to switch to the PACE managed care plan in your area. It is both a Medicare and Medi-Cal provider. So it is available to, and it's also available to non-Medi-Cal or non-Medicare participants as private pay. So for example, if you, there's a lot of different options with PACE. You can completely private pay, you can have Medicare, and then there's a different rate if you have Medicare. If you have Medicare and Medi-Cal, there would be no cost at all for PACE participation. We have heard that the private pay option is very expensive. I just talked to a gentleman who contacted his local PACE program because his mother's share of cost is extremely high. And I believe that that particular PACE program quoted him something like $5,000 a month. So as a private pay option, it may not be feasible, but definitely as a Medi-Cal option, it can be a really nice program for people. How to apply? First and most important is to confirm that PACE is even available in your community. It's only in 22 counties, and even within those counties, only in specific zip codes. So for example, there was a woman I was helping who her husband, she had kind of heard of PACE. And when we looked up, while Napa County, there is a PACE program, it does not serve their specific zip code. So before, if you're a professional and you're mentioning PACE, it would be really helpful to first figure out whether the person's zip code even falls within a PACE service area. Then you would contact a local program to apply and complete the assessment process. If you are considering PACE as a Medi-Cal benefit, you definitely want to make sure that you are already eligible for Medi-Cal before you communicate with PACE. We do have a good fact sheet that I've included here. And things to consider, PACE participation will not cause Medi-Cal recovery, but you do have to be willing to give up your managed care plan. And so one of the things that we talk with people about when we're talking about PACE is, my mom, she's had the same doctor for 20 years. And so you may really like Dr. Smith. Your mom may really like Dr. Smith. How often does she see Dr. Smith, and what is he doing for her? Versus this wraparound kind of full plate of services that Dr. Smith cannot provide, but that PACE can. And so, with all of these programs, it's looking for the program that's going to best meet the needs and the personality of the individual served. One of the things that one of our coworkers shared when her grandmother was looking at different services, they talked about PACE, they talked about CBAS program, those kind of center-based programs. And her grandmother said, I don't like old people. So she didn't want to hang out. She felt like even though she was in her 80s, she was very young at heart. But she, maybe thought that it was going to feel, like it wasn't for her. You can always visit these programs, and we do encourage people visit the program. If you're considering a PACE program, if you're considering a CBAS program for your loved one, it's okay to contact them, see what it's like. And some programs provide really tailored services to the community that they serve. So if there's more than one CBAS center or PACE center in your area, there may be one where more staff or more participants speak your loved one's language. So there's CBAS and PACE programs that cater more towards the Korean speaking community, the Spanish speaking community, Chinese. And so try to communicate with those programs and see, do you have any kind of culturally specific services that you can offer that may make your loved one more comfortable or you more comfortable? Okay, one thing to note with PACE, because it is wraparound, so because they offer both the in-home services and the center-based, it cannot be used in combination with other programs. It is the goal of PACE to really meet all of the individual's needs to help them avoid placement in a nursing home. Next up, if you are at all related to long-term care, if you've ever considered Medi-Cal, I think we've all heard of the magical assisted living waiver program, or ALW program. And it is a wonderful program, but it does have its limits. So ALW offers Medi-Cal beneficiaries who are 21 and over, it pays for their stay in an assisted living facility or in LA County in public subsidized housing as an alternative to nursing home placement. And what it does is Medi-Cal supplements the additional services that that person needs so that they can stay in an assisted living facility. And just to be clear about remain in the community, when someone is in an assisted living facility or an RCFE, because they are more home-like, we typically they would not be considered institutionalized. So it's a less restrictive environment. Many RCFEs or assisted living facilities are much more home-like. So this is a very small program. The ALW program is only available for very low income Medi-Cal beneficiaries who are eligible for full scope, no share of cost Medi-Cal, who also meet the required nursing level of care. On the ALW program, participants only pay for room and board, so that every year this changes slightly. I've included the figures here for 2022. And then Medi-Cal supplements any needed care and services. So in an RCFE, Medi-Cal may pay the facility to provide those additional services, or they may contract with a provider to come in and provide those services. In these few public subsidized housing programs that are in LA County, Medi-Cal pays for in-home care through a contractor. This is a very limited program. It's only available in 22 counties, and the current enrollment cap is 5,790. So if you've heard of ALW, you've also heard of the very, very long wait list. The wait list is currently, I think this is from last month, 6,559. And so that's why we hear of people that say they've been on the ALW wait list for 2 years. Great news. The program was just recently approved for an additional 7,000 slots for the entire state of California. So what's happening with those slots is they are being released across the 22 counties in which the ALW program is available, but the priority placements for those slots are going to individuals who are currently institutionalized. So those individuals who are currently on the ALW waitlist, have been on the waitlist, and are in a nursing home or a hospital. So we are very hopeful that these new slots will help kind of clear up a lot of that waitlist. How to apply. You must be eligible for Medi-Cal with no share of cost. There's just no way around that. You have to this is a program that's meant for very low income individuals. And then you need to contact the local care coordination agency for the county in which you wish to apply. We do have an ALW fact sheet that I've included here. And one question we get all the time is, what do we do about the wait list? How can I get prioritized? And then, unfortunately, someone who is, for example, at risk of eviction, I'm going to lose my apartment next month. That is not, or, I'm running out of money. Unfortunately, those are not reasons that the ALW program considers for prioritization. But if you are already on the wait list and you enter a hospital or a skilled nursing facility, you can be prioritized. So as soon as you or your loved one enters a facility, an institutional placement, if they're on the ALW waitlist already, contact that care coordination agency that you applied with and let them know that you're in a facility. So that is the way that people can be prioritized on the ALW waitlist. ALW participation is subject to Medi-Cal recovery. And again, we're going to be talking about the steps you can take to protect yourself. If you do not live in a county with the ALW program, what is unique about this program is that, for example, with PACE, if there's no PACE provider that serves your area, there is no PACE provider. The terrible option would be you need to move. But in this case, if you are willing to move to a different county that does have ALW, you can actually get on the wait list if if a slot opened and you live in a county that doesn't have ALW, but Los Angeles does, and you would be willing to move to Los Angeles, you can contact the care coordination agency for that county and you can apply to be on the wait list. Next up is the California Community Transitions Program, or CCT. So this provides support to nursing home residents, or it could be an individual who's also in a hospital, who are able to live independently with support with the transition back to the community. So this program, the goal is to help people who have been in an institution for more than 60 days, and so that's a hospital or a nursing home, with everything they need to get set up in the community so that they can live successfully at home. It doesn't mean that all their problems have been resolved, they're completely recovered, and they can do everything and completely live independently. It's helping them figure out what they need to get their home set up and their life set up so that they could live independently with support. So through CCT, they can provide both home and vehicle adaptations. They can provide home setup, assisted devices, wheelchairs, medical equipment that can include specialized beds, possibly Hoyer lifts. They can offer trainings on self-care. They can offer nursing visits, and they can help people enroll in other programs for the ongoing in-home care that they need. This is a program that's available statewide. I have an example of an individual right now who is connecting with CCT, and luckily he was able to connect successfully. He had, I think, they still don't really know, but 80 years old, pretty good health, had an incident, a ruptured vein in his brain, completely incapacitated, has now been in a nursing home for 3 months. His wife really wants to bring him home. He has improved somewhat, but he's not able to do the things that he was able to do before this incident. So he's lost the use of his entire right side of his body, but he and his family feel that he would be healthier at home and he would be happier at home. So connected with the CCT program that serves his county, they are going to help the family with buying a specialized bed, because his wife needs to be able, she's also in her 80s, be able to help him get in and out of bed, provide him with a shower chair, provide him with a wheelchair, and they're going to help him connect to other ongoing in-home services that he needs so that he can remain in the home. You must be eligible for Medi-Cal in order to apply for CCT, and you must currently be living in a skilled nursing facility or be in a hospital for more than 60 days. So once you leave the facility or the hospital, you can no longer apply for CCT. You need to contact a CCT lead organization to start the application process, and I've included the link to the list. And so some counties have more than one provider. I'd advise you just to call them. In this case, what I did, there were 4 providers for his county. One of them said they no longer provide CCT services, and then just went to the next person that would actually answer the phone and sounded pleasant. CCT is not subject to Medi-Cal recovery, and it can be really helpful for those people who have lived in a nursing home for, more than 60 days and want to leave, but need help putting services in place so that they can live in the community. So one of the questions that was submitted in advance was, are there any good HCBS programs for people that have lived in a nursing home for a year? Yes, this would be ideal. CCT would be great for someone who's lived in a nursing home for a year. They have maybe family and friends that are willing to help kind of coordinate care, but they just need some help with that transition, with navigating what that transition would look like. Yeah. Okay, so that was a lot of information, and we are going to have time for questions, but for now, I'm going to turn it back to Bea so we can take a quick look at Medi-Cal recovery.
Thank you. Alrighty, so next slide, please. Okay, so what is Medi-Cal recovery? Well, after a Medi-Cal recipient passes away, the state may seek repayment for services that they covered while the Medi-Cal recipient was alive, but only if they use their benefits for nursing home care, intermediate care for the developmentally disabled, specific home and community-based services like the Assisted Living Waiver Program, MSSP, or the HCBA waiver program, as well as other related hospital or prescription drug services that they received while either participating in those programs listed above or while they were in a nursing home. So it's really important to note that just because you are on Medi-Cal does not necessarily mean you're subject to Medi-Cal recovery. You would have had to actually use your benefits for these specific programs to be subject to recovery. And next slide, please. And thank you. So I'll also go over the different additional limits to Medi-Cal recovery, which include recovery only being limited to those who are 55 years of age or older. And recovery only happens when the assets are subject to probate, meaning there is no recovery if nothing was left in the name of the Medi-Cal recipient when they passed away or when they pass away. Also, if the property avoids probate, so this is either if the Medi-Cal recipient set up a living trust or they put their home in a joint tenancy, they have a pay on death account. Life estates are not subject to recovery. Mobile homes and manufactured homes are also not subject to recovery. However, if the Medi-Cal recipient happens to own the land in which the mobile home is on, depending on the value of that land, it may be subject to recovery. In addition, small estates with a value of less than $1,666 and $250,000 or less is exempt from recovery as well. You would just have to submit a small estate affidavit to the recovery unit. And then if you happen to own real property that's worth less than $55,425, that is also exempt from recovery. Finally, if you or if the Medi-Cal recipient happens to have a surviving spouse or registered domestic partner, their estate is automatically exempt from recovery and a claim is prohibited and forever barred. The only time that Medi-Cal can recover is if the surviving spouse or registered domestic partner ends up getting on Medi-Cal and uses their benefits for the recoverable services that I mentioned in the previous slide. But even then, Medi-Cal will only recover for what the surviving spouse or registered domestic partner used. We included our booklet on Medi-Cal recovery. It goes over all of the services subject to recovery, which I just mentioned, the ways that you can avoid recovery in the future, and what to do when the Medi-Cal recipient passes away, because you do have to notify the Medi-Cal recovery unit. In addition, the booklet also goes over the Medi-Cal recovery rules prior to 2017. So if you happen to know anyone who may be subject to recovery and they passed away before the new laws took effect, we have some information on that as well. Next slide, please. And then next, I just wanted to go over briefly the different home and community-based programs that are subject to recovery. Maura did go over them in her slides, but here's, this is a more summarized slide for you. So the HCBS programs that are not subject to recovery would be IHSS, the CFCO program, PACE, CCT, and CBAS. So if you only use these services while you're on Medi-Cal and you don't end up using any nursing home services or any other recoverable services, you will not have to worry about Medi-Cal recovery in the future. The HCBS programs that are subject to recovery would be the Assisted Living Waiver Program, the MSSP program, and the HCBA waiver. So these programs are subject to recovery. So if you happen to participate in any of these and you want to avoid recovery in the future, make sure to talk to an estate planning attorney to decide which options would be best for you. And next slide, please. So just wanted to transition over to CANHR's lawyer referral service. We are the only state bar certified lawyer referral service in California that specializes in elder law issues. So if you want to talk to an estate planner, either to avoid recovery in the future, or if you just want to do some estate planning, to make sure that your beneficiaries get what you want them to receive after you pass, we can definitely help you with that. Our estate planners also specialize in Medi-Cal planning. So this is more for people who are over the asset limits and they want to figure out the best ways to either transfer or spend down their assets. If you're worried about the look back period, our estate planners can definitely talk to you about how to either minimize or avoid the look back period transfer penalties. In addition, we also have litigators on our referral service who specialize in physical abuse and neglect in care homes, as well as elder financial abuse caused by financial institutions. So like banks, insurance companies, professional fiduciaries. So if you are interested in this, next slide, please. You can actually go on our website, submit an online referral form, or you can give us a call on our 1-800 hotline and talk to the lawyer referral specialist. That would be myself and our staff attorney, John Hafner, if it's regarding a personal injury situation. You can also email CANHR if you have any additional questions. But other than that, that's all for Maura and I. Thank you so much for listening. And so now we'll go over questions. We'll briefly go over the ones that we received first, and then we'll open it up to everyone. Give me 1 second. Alrighty. Maura, did you want to start off first?
Yeah, I can start. So we did receive quite a number of really good questions in advance. Thank you everyone for your questions. There were so many, I'm not sure we'll be able to get to all of them today. So if we don't get to yours, you are certainly welcome to send me or Bea an email. Some of you already did. Apologies, since I was preparing for this, I couldn't answer them in advance. But the first one, are there specific Medi-Cal programs for substance use disorder for people with disabilities or people over the age of 65? So the best answer for this is to contact the person's managed care plan. There is an initiative called CANHR, which is supposed to help coordinate specialized services for high-risk individuals. And so that includes individuals with, who have issues with substance abuse, alcohol abuse, who are high risk for homelessness. So each managed care plan coordinates their own specific services of what they provide, but they are supposed to be tailored to that person's needs. So CalAIM is a relatively new initiative from the state of California. So we do foresee there, at some point the need for a lot of the managed care plans to kind of be on the same page and have some consistency in services. But yes, there should be services available to that individual through their managed care plan. So the best advice is to contact the person's managed care plan. The next question is, how will the asset limit changes impact the assisted living waiver program?
So for that, it's not going to impact the assisted living waiver program. I mean, it will just mean that if you happen to have more than $2,000, if you happen to have $130,000 or less, you'd be eligible for Medi-Cal. But then to get the assisted living waiver program, you'd have to make sure you have no share of cost Medi-Cal. So it'd be dependent on your income.
Is there a way to proactively put services in place for a patient who will need care before they go home so they aren't waiting while they need care? That's a really great question. So if there's someone who's in a hospital or a nursing home, There are services that you can apply for while they're institutionalized if it's expected that they're going to return home within a relatively short period of time. CCT, or the California Community Transitions Program, is the one that I mentioned that helps with that transition back to the community for people who have been institutionalized for 60 days or more. The HCBA waiver would be for more high need individuals who maybe need in-home respite, respite nursing services. That also could be a consideration. IHSS is a program that people can apply for. So a couple of things. First, they have to be Medi-Cal eligible first to apply for any of those programs, IHSS, HCBA, or CCT. So if they haven't yet applied for Medi-Cal, they need to, because that is its own process, 45 days. Let's all pretend we live in a perfect world where all timelines work according to plan. And so 45 days for Medi-Cal eligibility. IHSS, county to county, it's administered by the local county. And so that as well is an assessment process that is usually 45 days as well. So we hear from people across the state that the family tried to apply for IHSS for their loved one that's in a nursing home and plans to return home very soon. And that the local IHSS program told them that they could not do an assessment in the nursing home. That is not true. There is guidance from the state for IHSS workers that they can begin the assessment process if the person plans on and is able to, that they wouldn't do an assessment on someone who just expresses a desire to go home, but that's not going to be a reality. But someone who's really nearing their discharge date in a nursing facility, IHSS can do the assessment. My suggestion is please reach out. We have an all county letter that we can provide you so that you can unfortunately educate that IHSS worker about what their role is. Are home and community-based services available for seniors who have been in nursing home for over a year? I'm sorry, yes, we did talk about that. Is there a good way to deal with wait lists for programs? There are some programs that do have wait lists. Unfortunately, so IHSS, again, no wait list, but it can be really hard if you don't have a worker kind of lined up. The biggest wait list is the ALW program. The only way to get prioritization on that wait list is for people who have been institutionalized. So they're in a nursing home or in a hospital. So we just suggest that if you're on the ALW wait list, that you contact your care coordination agency as soon as possible. Individual MSSP programs may have a wait list. I'm not aware of any advice for prioritization on the other wait lists as far as for HCBA or MSSP, really. Yeah. When will the Medi-Cal income allowance be raised?
We do not know yet. There is currently legislation in place that advocates to raise it, but we have to wait on legislation to, pass the bill. So once that happens, though, you can bet that you'll get an alert to let you know that the income allowance has been raised.
And one thing to note is that that the numbers that Bea talked about today for aged and disabled and Magi Medi-Cal, that 1564 number for individuals and the 2106 for couples, that typically changes every year because it's based on the federal poverty level. So every year, the federal poverty level typically is updated. And so there is a slight increase year to year. So it's just important to remember that usually happens around, it's usually effective in April of every year. So if someone, is, let's say, somewhat close to that income cutoff, but they're just not there yet, they could be, within the next year or two. So just important to remember, not that we expect anybody to be able to quote Medi-Cal facts and figures off the top of their head, but, check back in and see how the numbers have changed year to year.
Mm-hmm. And then so what I was talking about was the maintenance need level, which is that $600 figure that we use to calculate the share of cost. There's currently legislation for that, but we don't know yet when that will be raised. And then we just have a few more questions and then we'll open it up to the audience. So the next one is is there other way to reduce someone's share of costs other than purchasing extra health dental insurance? Um, the answer is it depends on where you live. So if you're in the community, you can only use the additional healthcare insurance to reduce your countable monthly income. If you live in a nursing home, however, you can, the name of the case is, I forget them, but you can, if you get a doctor's note to show that you need a specific medical supply, you can use the money that you use to pay for that as a to reduce your countable income for share of cost.
And that would be Hunt v. Kaiser and Johnson v. Rank.
Thank you. The next question is, do the gifting rules apply also to community-based Medi-Cal? Yes. Well, no, sorry, no. The look back period is only triggered when you enter a nursing home. So if you remain in the community, you can transfer and gift as much as you'd like without affecting your eligibility. The only thing to remember is that, no one has a crystal ball. If you end up having to go into a nursing home, if you happen to make any transfers within the past 30 months, that may make you ineligible once you transition to long-term care. The next question is, do VA disability payments for veterans count as income for Medi-Cal? So VA aid and attendance benefits do not, but I do know that there's other types of benefits that may. Maura, do you happen to remember what that is?
So if it's disability related, my understanding is that it is not counted. There is, so I was talking with a woman recently who was talking about, so she is receiving VA survivor benefits. So they're not related to a disability. So that would be counted as income. So there's a lot of different things that Medi-Cal counts when they're calculating, your eligibility for no share of cost Medi-Cal. If you ever have specific questions, you can certainly contact CANHR. We'll be happy to look at that person's kind of specific situation and their specific dollar amounts. Particularly for spousal impoverishment, it can be really confusing. And so honestly, when I was first learning it, the best way to do it is just get someone on the phone and say, how much does the one spouse make? How much does the other spouse make? And let's do the math together.
Right. And last question is, what happens if you are on Medi-Cal using HCBA, but need to go into a nursing home for medical reasons eventually? So once you enter the nursing home, you'll automatically transition into Medi-Cal for long-term care. So you won't be able to receive your HCBA services anymore, because the expectation is the nursing home should provide all of the services you need. And then you'll also transition to a different Medi-Cal program. Okay, so now we can open it up to the questions on the chat.
And if you have a question you'd like to ask, there are a few that are already, it sounds like, so I know Pauline, who's on with us, has been answering some of your questions. Thank you, Pauline. We appreciate that. People don't have to wait. One question that I noticed, it sounds like the transition to home and community programs are only applicable when living in a hospital or a nursing facility, not if you're currently in an assisted living. Yes, and that goes back to my earlier comment about what we consider being in the community, what Medi-Cal considers being in the community versus being institutionalized. So an assisted living facility or an RCFE boarding care, they do not consider that an institutional placement. So these kind of transition programs where the requirement is that someone has been institutionalized, especially for CCT, they had to have been in a hospital or a nursing home. I do want to mention HCBA, where there is that, requirement that someone has been institutionalized or they are at risk of institutionalization. So let's say that the person, is at risk for institutionalization. It's not to say that if you're in an assisted living program, you can't receive some of these home and community-based services programs. It's that some will provide them if you're in an RCFE, some will not. And then you also have to balance that with what should the RCFE be providing you, because likely you are paying for, most people are paying privately for services. So if you have kind of specific questions, you can always call us.
Oh, Maura, just wanted to piggyback off of that. There was one question in the chat that asked, can you apply for multiple HCBS programs?
Yes, yes. So a good example would be a client who she was living at home. Her daughter was the IHSS caregiver, right? So she lived with her adult daughter. Her daughter was paid to be her in-home provider, but the daughter felt like she needed a break. She needed some time during the day to, to be able to know that her mom would be safe. She didn't feel like she could leave her mom alone. And so what are the options for a family like that? One could be, would the mom be willing to attend a CBAS adult day program during the day, for a couple of days? Another option, let's say the person can't get out of bed. So, a CBAS program is not going to work for them. For IHSS, you can split caregivers. So if you have a caregiver who's a spouse or a child, an adult child, they can be paid for that work, but it can also just be exhausting. So one thing that we try to let people know is that you can split hours with more than one caregiver. That's another possibility. I do believe that you can receive, and Pauline, I'm not sure. So IHSS and HCBA, I think you can use those in combination.
Yes.
So I think you can have IHSS and then add, let's say, nursing or respite hours on top of your IHSS through HCBA. So there's different programs. The exception, like PACE program, no, you would just enroll in PACE because that program's goal is to meet all of that person's need. They provide both in-home care and therapy, rehabilitation, center-based, social services, meals, everything. So that was a really long answer to your very short question.
Great answer.
Great answer. Yes. Okay.
Okay, Bea, I understood that the new asset limits also apply to the MSP programs. I'm sorry, I'm not sure. Oh, I think you're talking about Medicare programs. And so the asset limit changes apply to all non-Magi Medi-Cal programs. Today, we chose to focus on very specific Medi-Cal programs because that is largely the population that we serve, but there are a lot of different Medi-Cal programs. If it is a non-Magi Medi-Cal program, then yes, the asset limit changes apply to all of those non-Magi programs. And so the goal of these changes is, as you saw on Bea's slide with the different programs, Magi Medi-Cal, which is for people 19 to 64, there's no asset limit. It's been that way. And so the goal on California's part is to align the other Medi-Cal programs with Magi Medi-Cal, so that there's no asset limit for any of the Medi-Cal programs. Sorry.
I have one. So one question was, what if the couple both have Medi-Cal and one spouse needs SNF? And I think this applies to the spousal impoverishment protections. So I can answer that. If they're both on Medi-Cal and one spouse is in the SNF, they're just spousal impoverishment will only apply to the income protections. As far as assets, the Medi-Cal spouse at home can retain up to $130,000, and then the nursing home spouse can retain $130,000 in assets. But so they can't, in other words, they can't receive that CSRA that we talked about. However, if the community spouse makes less than $3,435, the nursing home spouse can still allocate. Oh, sorry, Mark.
It depends partly on when the spouses were on Medi-Cal. So unfortunately, if they were both on Medi-Cal, and we're not going to lie to you, there are 5 billion Medi-Cal rules, and each of them is very unique and very complicated. And so we do, if you have specific situations, please do give us a call. We're happy to walk through, these situations with you. There's a unique way that Medi-Cal looks at couples. It really depends on whether they both got on Medi-Cal at the same time, whether they can get that income allocation or not, or whether one was on Medi-Cal and getting spousal impoverishment, and then the other one got on Medi-Cal. So there's a lot of what ifs, but there must be a community spouse in order for there to be spousal impoverishment protections. And what that means is at least one spouse or registered domestic partner cannot be receiving Medi-Cal. So if you have two individuals who were in the community on Medi-Cal, there was no community spouse because they both were getting Medi-Cal at the same time. But as Bea mentioned, when one of the spouses goes into a nursing home, when you enter a nursing home, Medi-Cal looks at you and your income and your assets as if you are by yourself. And so what happens to that couple that was in the community is that now they have different asset limits. They get separated into two different households. So there are some unique situations where income allocation can continue when the person who wasn't on Medi-Cal needs to get on Medi-Cal, but it can get pretty complicated. So we do suggest that you give us a call when you have those kinds of situations. And that kind of leads to Karen's question as far as, does CANHR have folks that act as navigators for folks applying to Medi-Cal and their subsequent programs? I would definitely not call us navigators. I used to work at a program that I ran a navigator program. Navigators do a lot more hand-holding. It's important for a lot of people who contact us frequently that you understand that we have 14 staff and we serve the entire state of California. So, we hear callers sometimes that say, well, I want you to come down here and help me fill this out. And I'll say, where do you live? I live in Sacramento. And I say, well, I'm in South Pasadena. So that would be really hard for me to do. So we provide over the phone counseling. We provide, information, fact sheets. We hold these kind of consumer education. And then we provide a lot of technical assistance to local programs in your community that can act as navigators and can help you with this. So if you're a professional who does provide navigation, system navigation, we want to talk to you. We want you to understand how Medi-Cal works so that you can provide that kind of navigation assistance. So we're not exactly navigators, but we'll definitely talk you through situations and then try to find you a program that can help you really do the system navigation piece. Okay. All right. Does Medi-Cal pay for dental services? Oh, I'm sorry. So Pauline did answer that question already. And so Medi-Cal does pay for some dental services. And Pauline's suggestion was to contact the local managed care plan for assistance. Sometimes there can be a need for advocacy around dental services. We understand that while dental benefits were restored, it can be hard to actually get dental benefits. So this is a lot of information, and we really appreciate those of you who attended today and who stuck with us through the entire presentation. I'm sure we weren't able to get to everything, but again, please follow up with us. You can send us an email. We'd be happy to. You can also call our 1-800 number, and we can talk through your specific scenario. So, Bea, thank you so much for your time. Pauline, thank you for your time. And thank you to everyone, and we hope you have a good rest of your day.